So coming back to the blood pressure distributions we talked about previously, we said that moving the threshold of the test will change the proportion of people falsely and correctly classified as diseased and as healthy. Or let's pick another example relating to heart failure. Let's say we have a group of 10 patients with heart failure and a group of 10 healthy controls without heart failure. This is the concentration of BNP, or brain natriuretic peptide, a marker of heart failure. So people in the heart failure group on average have higher levels of BNP. One's up here, one's here, and so forth. Individuals without heart failure have lower levels, but as we've seen previously, there will be some overlap. So if we set our threshold at a lower level, we'd correctly classify 8 out of the 10 diseased. 2 would be falsely classified as healthy. However, 7 out of the 10 healthy controls would be falsely classified as diseased, whereas 3 would be correctly classified as non-diseased. What are the sensitivity and specificity? The sensitivity would be calculated as 8 true positives divided by all diseased folks, or 80%. And the specificity would be calculated as 3 true negatives divided by all non-diseased individuals, or 30%. And what happens if we move the threshold to a much higher level? Well, in this case, we'd only pick up 2 diseased individuals, or true positives, and we'd miss 8 people, or false negatives. Turning to the non-diseased, we'd correctly classify a much larger proportion of non-diseased individuals. So 9 out of 10 non-diseased would be correctly classified, and only 1 individual would end up as a false positive. So the sensitivity is 2 divided by 10, or 20%, and the specificity is 9 divided by 10, or 90%. So moving the threshold is usually a compromise between sensitivity and specificity. As one goes up, the other one goes down, and vice versa. Sensitivity and specificity are great for public health purposes because they tell us how many diseased individuals in our population we're going to pick up with the test and how many non-diseased we'll be able to rule out. However, the clinician needs to know slightly different indicators of validity because she's confronted with positive or negative test results and will have to decide what to do with them. And these additional indicators are going to be covered in the next lessons.